All procedures in this section imply that these services are performed by, or are under the direct supervision of, a physician, and that all instruments, equipment, fluids, gases, probes, catheters, technicians' fees, medications, gloves, trays, tubing and other sterile supplies be provided by the physician. When the physician only interprets the results and/or operates the equipment, a professional component, modifier 26, should be used to identify physician's services. Simple cystometrogram, CMG, e.g., spinal manometer. The physician inserts a pressure catheter into the bladder and connects it to a manometer line filled with fluid to measure pressure and flow in the lower urinary tract. Complex cystometrogram, i.e., calibrated electronic equipment. With urethral pressure profile studies, i.e., urethral closure pressure profile, any technique. With voiding pressure studies, i.e., bladder voiding pressure, any technique. With voiding pressure studies, i.e., bladder voiding pressure, and urethral pressure profile studies, i.e., urethral closure pressure profile, any technique. For a complex cystometrogram, the physician inserts an electronic microtip pressure transducer catheter into the bladder and connects it to electronic equipment to measure pressure and flow in the lower urinary tract. Simple uroflowmetry, UFR, e.g., stopwatch flow rate, mechanical uroflowmeter. Complex uroflowmetry, e.g., calibrated electronic equipment. For simple uroflowmetry, 51736, the physician assesses the rate of emptying the bladder by stopwatch, recording the volume of urine per time. For complex uroflowmetry, 51741, the physician assesses the rate of emptying of the bladder by electronic equipment, recording the volume of urine per time. Electromyography studies, EMG, of anal or urethral sphincter, other than needle, any technique. The physician places a pad in the anal or urethral sphincter and measures the electrical activity with the bladder filled and during emptying. Needle electromyography studies, EMG, of anal or urethral sphincter, any technique. The physician places a pad or needle in the anal or urethral sphincter and measures the electrical activity with the bladder filled and during emptying. Stimulus evoked response, e.g., measurement of bulbocavenosus reflex latency time. The physician electrically stimulates the head of the penis. The physician measures the delay time for travel of stimulation through the pelvic nerves to the pudendal nerve. Voiding pressure studies, intra-abdominal, i.e., rectal, gastric, intraperitoneal. The physician places a transducer in the abdomen to measure intra-abdominal pressure during emptying of the bladder. Measurement of post-voiding residual urine and/or bladder capacity by ultrasound, non-imaging. Residual urine and/or bladder capacity is measured by ultrasound after the patient has voided. A portable ultrasound scanner is used for this purpose. Operation of the scanner is done simply by directing the scanning head over the suprapubic area while the patient is lying down in the supine position. The software built into the scanner calculates the post-void residual urine volume immediately and also does calculations for the bladder capacity based on the individual's bladder shape and not on fixed geometric formulas. A trephine is an instrument used for cutting out a round piece of skull bone. Twist drill hole for subdural or ventricular puncture. Twist drill hole, S, for subdural, intracerebral, or ventricular puncture, for implanting ventricular catheter, pressure recording device, or other intracerebral monitoring device. For evacuation and/or drainage of subdural hematoma. The physician uses a manually operated twist drill to create an opening in the skull. The physician incises the scalp and peels it away from the area to be drilled. The physician places the drill over the affected area of the skull and twists until the drill pierces the periosteum and the dura is exposed. Fluid may be drawn off from the subdural space or from the ventricles. In 61105, the hole is made to alleviate pressure, and is used for subsequent surgery. In 61107, the hole is used to implant a ventricular drainage catheter, a fluid pressure recording device, or other intracerebral monitoring device. In 61108, the hole is used to access and evacuate or drain a subdural hematoma.
Burr hole, S, for ventricular puncture, including injection of gas, contrast media, dye, or radioactive material. The physician uses an electric burr drill to create a ventricular puncture to inject diagnostic fluid. The physician incises the scalp and peels it away from the area to be drilled. The physician places the drill over the area to be injected, and drills until the periosteum is reached. A ventricular puncture is made. The ventricles may be injected with gas, contrast media, dye, or radioactive material for diagnostic purposes. Burr hole, S, or trephine, with biopsy of brain or intracranial lesion. With drainage of brain abscess or cyst. With subsequent tapping, aspiration, of intracranial abscess or cyst. The physician uses a burr drill or trephine to create a hole in the cranium through which a brain or intracranial lesion or abscess is located. An abscess or cyst may be drained. The physician incises the scalp and peels it away from the area to be drilled. In 61140, a lesion biopsy is obtained using a forceps or curette. In 61150, a catheter is placed through the hole and into a brain abscess or cyst for drainage. Report 61151 for subsequent drainage of the abscess or cyst through the original burr hole.
Burr hole, S, with evacuation and/or drainage of hematoma, extradural or subdural. The physician drills a burr hole in the cranium to drain a hematoma. The hematoma is identified using separately reportable computed tomography, CT, scan. The physician incises the scalp and peels it away from the area to be drilled. The physician uses a burr drill to access the hematoma. An extradural, epidural, hematoma is located outside the dura, just under the periosteum. A subdural hematoma is located under the dura mater, which must be incised to reach the hematoma. The hematoma is decompressed and bleeding is controlled. For subdural hematomas, the dura is sutured closed. The scalp is repositioned and sutured into place. Burr hole, S, with aspiration of hematoma or cyst, intracerebral. For implanting ventricular catheter, reservoir, EEG electrode, S, pressure recording device, or other cerebral monitoring device. The physician drills a burr hole in the cranium to aspirate a hematoma or cyst located in the brain. The hematoma or cyst is identified using a CT scan. The physician incises the scalp and peels it away from the area to be drilled. The physician drills through the cranium to the dura mater, which is incised. The brain is dissected and retracted until the hematoma or cyst is located. The hematoma or cyst is aspirated using a syringe if the fluid is to be sent to pathology. Otherwise, the fluid is irrigated and suctioned. The dura mater is sutured closed and the scalp is repositioned and sutured into place. In 61210, a ventricular catheter, reservoir, EEG electrodes, pressure recording device, or other cerebral monitoring device is placed through the burr hole following aspiration of the hematoma. These devices or monitors are used to follow intracranial pressure and cerebral function following surgery. Insertion of subcutaneous reservoir, pump or continuous infusion system for connection to ventricular catheter. The physician places a device for administering chemotherapy or other medication into the cerebral spinal fluid. The physician makes a skin incision at the level at which the catheter will be inserted into the reservoir. A dermal or subdermal pocket is created with blunt dissection. The reservoir is connected to the catheter and tested to ensure function. The pocket is sutured in layers. Burr hole, S, or trifine, supratentorial, exploratory, not followed by other surgery. Burr hole, S, or trifine, infratentorial, unilateral or bilateral. In 61250 the hole is made to access the supratentorial area of the brain. In 61253, the infratentorial, unilateral, or bilateral area of the brain is accessed. The physician makes an incision in the scalp over the area to be drilled, and uses a burr hole drill or a trifine to create an opening to the brain. The physician explores the area and closes the wound. No other procedures are reported at this time. When burr holes are drilled into the infratentorial area followed by a craniotomy during the same operative session, should 61253 be reported in addition to the appropriate craniotomy code. The craniotomy codes listed in the craniectomy or craniotomy subsection, codes 61304 to 61321, include burr holes or trifine performed prior to the craniotomy during the same operative session. Therefore, code 61253 should not be reported separately during the same operative. Venipuncture, younger than age 3 years, necessitating the skill of a physician or other qualified healthcare professional, not to be used for routine venipuncture, femoral or jugular vein. Scalp vein. Other vein. A needle is inserted through the skin to puncture the vein. The needle is inserted into the vein and used for the withdrawal of blood for diagnostic study or for the therapeutic infusion of intravenous medication. A soft flexible catheter may be placed for prolonged therapy. Once the procedure is complete, the needle or catheter is withdrawn and pressure is applied over the puncture site to control bleeding. Use this code for venipuncture necessitating a physician's skill, not when routine venipuncture is performed. Venipuncture, age 3 years or older, necessitating the skill of a physician or other qualified healthcare professional for diagnostic or therapeutic purposes, not to be used for routine venipuncture. Venipuncture, cut down, younger than age 1 year. Age 1 or over, not to be used for routine venipuncture. The physician makes an incision in the skin directly over the vessel and dissects the area surrounding the vein. A needle is passed into the vein for the withdrawal of blood or for the infusion of intravenous medication of a patient. A catheter may be left behind. Once the procedure is complete, the incision is repaired with a layered closure.